So I now declare the meeting open to the public online, and can I welcome all the members who are participating by video conferencing and remind members about the protocols regarding the use of electronic devices. And the first item I will go to then would first of all go to apologies and then I'll go to the clerk, but have there been any apologies received, clerk?
Just Chair, that Gordon and Jonathan will be a bit late to the meeting.
Okay, thank you. And we have all other members online, so there's no other apologies. Thank you. So I'd just like to then, clerk, ask you to outline there the committee decisions in relation to the health and social care bill, please.
Thanks, Chair. So this is the committee have requested the department consider amendments in the following areas. So it's in relation to the local engagement and input in relation to commissioning decisions, the transition arrangements for that once the board and LCGs are dissolved, the scrutiny that the committee is able to provide during that transition period, the governance framework of the new structures. The committee would like to see the department consider amendments in that area. And then there's a couple of areas the committee were wanting further clarification, and that's in relation to the appeals process, and then also in relation to the transition of staff across the BSO. So if members are content, those are the areas that will flag to the department that the committee are wanting amendments and further information on.
Yeah, members content. Carol?
Yeah, Chair, it's just obviously we raised it in closed session, but just to try and find out if if it's possible to get an urgent update from the Minister on that bonfire outside a fire station in Ards, if that can be done today, please.
Yeah, I think we had agreed that would be done, and see can we get some information back on that urgently. Paula, your hand is raised there. Is that from the previous session? Yeah, thank you.
Sorry, Chair, previous.
Okay, so members agreed as outlined by the clerk there in relation to the HSC bill. Thank you. Okay, members, so in terms of chairman's business, waiting lists, I think given the focus that we've had on waiting lists, and we're very aware and we have welcomed the elective care plan that the Minister has set out, I think it would be really useful at our first meeting back if we could get an update from the department on the immediate actions that they outlined in that plan, so we can hit the ground running in terms of that autumn period. So if we could ask the department to come back and brief us at our first meeting in relation to that item, and also if we could look at getting, I think, a quarterly update on the waiting lists, maybe a written update monthly, but also make it a standing agenda item so that we can keep a track on progress with the waiting lists and play our part in relation to that. Would members be content with that? Thank you. Also, just to note the concern around the recall that was announced on Tuesday in relation to the 9,000 patients in the Northern Trust. And first of all, I'm sure all of our thoughts are with every one of the people who have been first and foremost caught up in that recall. It is, I think, and obviously this is additional pressure on staff and everything as well, and we're very conscious of how under pressure they are. So I think that's an area that we want to just keep an eye on, committee, as it goes forward. It is worrying that there's another major large-scale recall taking place, but I think it's important that it's robust and thorough, and now that it has been found necessary. I would also like to welcome the launch of the mental health strategy. I think that's useful, and I would actually think I'd look forward to maybe engaging with the Minister around the finance for all of these. There has been a number of significant announcements over the past number of weeks. Those are all going to be clearly reliant on workforce, on finance, on issues like that. So I think it'll be good to tease some of that out. Also, I'd like to welcome the fact that there has been a chair now appointed to the Muckamore inquiry, Tom Clark QC. I think that's a welcome progress in that, and I know, Carol, you have been working on maybe a informal meeting with the families. Yes, Carol?
Yes, Chair. So I raised this at the committee last week. So I agreed to pull together an informal meeting with the Muckamore families And I think it will be important, you know, since I get that word back, I'll do that. But Chair, we've now got ongoing inquiries, and I think it would be really appropriate if we could get an update before the meeting with the Minister next week on basically where all those inquiries are at, just to kind of get a situation report from where they're at, what stage they're at, what's going to happen, almost like a timeline for them. Because while they're welcomed, because it's about openness and transparency, there's a feeling that that's all kind of very process driven at this stage. And that's certainly come out to meetings I've had with different families. So if we could maybe get agreement to ask that, I'd appreciate it. Thank you.
Members content that we seek that update? Yeah, thank you. Okay. The other thing I did want to mention, members, in relation to, I'm very conscious today that today is sees the end of the EU settlement scheme, and I have a particular concern around the health element. I did a meeting in my constituency this week with a fantastic group of young people from East Timor, Timor-Leste, who had put together a container of goods for their own people back at home in East Timor as a result of the damage inflicted by Storm Seroja. However, I would be concerned that any kind of barriers to, and this is in particular in relation to the announcement of the autumn rollout of a booster vaccine. And I think it's crucial that people are confident and comfortable to come forward to seek the health support that they need in terms of that. And I think it would be maybe just useful if we write to the Minister flagging the fact that I believe that should be extended, but I certainly believe even if it's not extended, it needs to be made very clear that communities who may be at risk or feel uneasy about engaging with officialdom in any shape or form, including health, that will present a risk both to them and to the wider community. So I think it's something to be considered that the Minister would reflect that in light of that we're dealing with a pandemic, that we need to be hugely sensitive and we need to be putting in place measures that will provide reassurance to all communities. Would members be content with that? Yeah, thank you. And finally, members, just to flag that we do have a joint meeting at 1 p.m. today with the Committee for Justice, and we therefore need to stick rigidly to timings today. So I'll go to the draft minutes at item 4, and this is the meeting of the 24th of June, which are at tab 4.1 of your pack. Are members content with the minutes? Yeah. And are there any matters arising? There are no matters arising, no from those today, thank you. So we are now moving then to the departmental briefing. I'll just check, Clerk, do we have officials available at this point?
Yes, officials are available, Chair.
Okay, so members, item 6 then is a departmental briefing on health-related EU exit issues, including the scheme that was announced, the reimbursement scheme to allow people to avail of healthcare in the 26 counties, and the EU medical device regulations. Relevant papers are included at tab 6.1 to tab 6.4 of your pack. So I'd now like to welcome Department of Health officials to our meeting once again, and I think they've all been with us on several occasions. But so pleased to welcome Miss Kathy Harrison, who's the Chief Pharmaceutical Officer. Are you able to hear me okay, Kathy?
Yes, I am, Chair, yes.
Good morning, Kathy. And Miss Emer Smith, who is Senior Principal Officer in the EU Exit Transition Unit. Can you hear me okay, Emer?
Yes, thank you, Chair.
Thank you. Miss Patricia Quinn Duffy, who is EU Exit Lead in Reciprocal Healthcare and Workforce Issues. Can you hear me, Patricia? I'm not hearing you there, Patricia. You may be still on mute. So can you hear us okay?
Yeah, that's it now.
Okay, thank you, Patricia. Thank you very much. And Mr. David Wilson, and David is Senior Principal Officer for Safety, Quality and Standards. Can you hear us okay, David?
Yes, I can, Chair.
Okay, well listen, thank you all very much. You're all very welcome to Fáilte Rómha Lig, Guji and Rin Sláinte to this morning's Health Committee. And I'll go back to you then, Kathy, just in terms of outlining how you wish to deal with the briefing of committee members, and then we'll go into question and answer session.
Chair, thank you very much, and welcome the opportunity to give an update on EU-related issues as they affect health. Today, in advance of the meeting, quite a detailed briefing was given to you. It was submitted a couple of weeks ago, so there are some updates today that I'll give verbally as we go through. What I thought I'd do is I will outline some of the medicines issues, and then I'll hand over to Patricia and she'll take us through the sort of the people issues and services issues, and we'll leave a good bit of time for questions at the end, Chair, but just I'll just run through and remind members of the key issues around medicines, give an update on the EU negotiations as well, and then hand over to Patricia. So members will be aware that the Northern Ireland Protocol came into effect on the 1st of January this year, and under the Northern Ireland Protocol, Northern Ireland continues to follow EU laws and regulations, processes for goods, and that includes those for medicines and medical devices, and the key point here is that the GB is not obliged to do so, so there is a difference. The introduction of the Northern Ireland Protocol has implications for supply and regulation of medicines, and just briefly to outline those. Members will be aware as well that historically our model of supply of all of our medical products into Northern Ireland has relied upon free movement of supplies from GB into Northern Ireland, and that we regularly use a figure of around 98% of our medicines flowing from GB into Northern Ireland via that route. However, under the protocol, medicines moving from GB into Northern Ireland will be handled as goods entering EU from a third country, and this means that medicines will be subject to additional testing, specifically batch testing and some other verification. In addition, prescription-only medicines that are used in Northern Ireland under the protocol will have to have packaging that complies with the EU Falsified Medicines Directive, and this will not apply in GB. Now, at this moment in time, the EU Commission and the UK Government have agreed a grace period, which we are currently in, and that runs until the 31st of December. And that was introduced to provide additional time for businesses to prepare for the full implementation of the protocol. However, the full implementation of the protocol as it was written would have a major impact on medicine supplies if left unmitigated and there were no improvements made to those arrangements. And industry would have had to make significant changes to medicine supply routes in order to handle additional importation arrangements. Now, we are aware that the pharmaceutical industry have begun to consider the changes that they may need to make to their supply chains, and that they have been awaiting further information from the Department of Health and Social Care in relation to the arrangements by which they'll have to comply when the grace period ends at the end of this year. Now, the industry I meet regularly with representatives from industry, and I have to say that the complexity that these arrangements have introduced is really considerable. They are looking at their entire portfolios of medicines that they supply into Northern Ireland. I've met a wide range of companies, and they've all told me the same thing, and that is that they're committed to continuing to supply to Northern Ireland, but they are having to consider their options in relation to continuity of supply routes, and that they're considering different options such as rerouting from via direct from EU or direct into Northern Ireland, and using ROI, and also looking at things like joint packaging with ROI and issues like that. They're also advising me that there's a risk of discontinuations, and that there is a risk, without any mitigations obviously being introduced, that they could see that not all of their portfolio would transfer over following the end of the grace period. And members, again, I have previously advised that the pharmaceutical industry is legally obliged to give DHSC 6 months notice of any discontinuations to any part of the UK, and that includes anything to Northern Ireland, and that because of that, you know that at the end of June was a critical point for us in industry. We're stressing just that they were having to make business decisions and that this is a critical time. I have to advise the committee there have been a relatively small number at this stage of notifications of discontinuations of products that have been made into the Department of Health's portal. The information on that is commercial and sensitive, and numbers are low currently. In addition to some of the supply issues as well, just to remind members, there are also issues relating to the licensing of medicines. And since the start of January this year, if a medicine is licensed through the centralised authorised procedure, which is handled by the European Medicines Agency, and that covers our innovative medicines like new medicines, like cancer medicines, etc., then MHRA are in a position that they can authorise any variations to those centrally authorised central authorisations and licences, as we would call them. MHRA can authorise those changes in GB, but in Northern Ireland we have to wait for EMA to make the changes, and that is potentially an issue for us that we have to consider, because if there's any differences between the timelines between MHRA and EMA and their decision making, or if there's any differences at all between the conditions on the licence, for example, age groups or how the drugs can be used or stored or anything else, it can present difficulty. And we have had a recent issue that members will be aware of with the lung cancer drug Tagrisso. And this arose because Tagrisso was already a centrally authorised product, and the new indication for lung cancer that was approved, MHRA were able to make those changes quickly for GB, but we had a lag period where we had to wait for EMA. Now, to avoid delay in Northern Ireland, that was all managed, and patients had access to the drug. That was managed by us working with DHSC and MHRA in relation to that. But that's something we need to be aware of in future for centrally authorised products. And the other area relating to licensing affects medicines that are licensed through another process called decentralised or mutual recognition procedures. And there is a difference of opinion in relation to the location of specific functions for testing. And that was one of the areas, along with some of the supply areas that have been the subject of the current and ongoing negotiations with EU. So quite a number of issues really relating to medicines, and this is for that reason there has been ongoing discussion with the EU, because we wanted to reach some kind of an EU negotiated solution to say, look, a lot of these issues could not have been predicted a number of months ago. Now that we know more and we know some of the risks, and formal negotiations have been going on, and the UK government have been working with the EU Commission, and a number of proposals have been put forward from the UK, and the whole point of it is, and the whole aim is, that is to mitigate any risk to the continuity of our supplies into Northern Ireland as a consequence of the protocol. And I can advise the committee that yesterday, on the 30th of June, the EU Commission announced a number of solutions to help the implementation of the protocol. They are referring to a creative solution to ensure the continued long-term supply of medicines from Great Britain to Northern Ireland. The EU statement advised that the solution will involve the EU changing its own rules so that regulatory compliance functions for medicines authorised by the UK for the Northern Ireland market in accordance with the protocol may be located in Great Britain, subject to specific conditions, ensuring that the medicines concerned are not further distributed in the EU internal market. The Commission have also indicated in their statement that they will put forward a legislative proposal in early autumn in order to be able to finish the legislative process on time ahead of the grace period ending. Now, the proposal that has been received from the EU is currently being given very careful consideration. It's highly complex and covers a number of areas. As a result of this, unfortunately today I can't comment on any further details of the proposal, other than to say that it's being currently under consideration, and we will know more shortly. And whilst I welcome the announcement, which is very positive, and obviously a negotiated solution is always what we wanted to see in this space, we do need to see further details, and when I have seen those and have been able to brief my Minister, I will advise the committee, Chair, and come back with more details, so I can't provide a lot more details today. I did also want to just remind the members that as well as the ongoing negotiations which have been with the EU, there's been considerable work as well going on in the background between my team and myself and officials in DHSC and MHRA around other mitigations that might be needed to maintain supplies of medicines, because we can't risk any interruption in our medicine supplies, as you know. So that work is still going on, and obviously whenever the fine detail of the EU negotiation is known, we will know which of those mitigations can be stood down or which may still need to be taken forward. Moving on from medicines, in terms of medical devices, just since the last update that I gave you, a couple of things have happened. So a statutory instrument called the Medical Devices Northern Ireland Protocol Regulations 2021 was laid on the 16th of June. Also, the EU medical device regulations came into effect here in Northern Ireland on the 26th of May. And also a brief update on data adequacy, and that is to say that on the 28th of June, the EU Commission adopted 2 adequacy decisions for the UK. And the EU have indicated that this means personal data can now flow freely from EU to UK. Chair. So that's the end of my update, Chair. If you're content, we can hand over to Patricia.
Yeah, absolutely. Thank you, Cathy. And yeah, certainly we'll go across then to yourself, Patricia. Thank you.
Thank you, Chair. Now to update on the people and services elements. In terms of reciprocal healthcare, there hasn't really been any movement since the introduction of the Trade and Cooperation Agreement and the Social Security Protocol. However, the Irish and the UK have been in negotiations around the overlap between the MOU between the Ireland and UK and the TCA as to which would apply. They still haven't issued any guidance on it yet, but we're expecting that there will be an exchange of letters fairly shortly, which will be publicised, and at that point I'll share those with the committee so that there's an identification of which protocol applies in which circumstance, because some of the provisions are slightly better in the MOU than they are in the TCA for British and Irish citizens in the 2 jurisdictions within the CTA. So that should be fairly shortly provided. The other thing that we've done around reciprocal healthcare is that guidance has been shared with stakeholders within the HSC, the patient payment officers, the family practitioner services and the board. And we've had discussions around applications of the EU withdrawal agreement and the trade and cooperation agreement. So we've sent that out for some feedback, because obviously on the ground there's always complications and sort of applications that they need to have a little bit more information. So that is an ongoing process with the operational colleagues. The major announcement that we've had probably this let's just bring it up here. This month is around the Minister requesting the reinstatement of a temporary scheme similar to the Cross-Border Healthcare Directive. So this opens today in the board, and they will be accepting applications from today. And it allows ordinary resident patients in Northern Ireland to seek treatment in the Republic of Ireland and have the costs reimbursed up to the cost of the treatment to the HSC in Northern Ireland. The proposed scheme is an administrative scheme that has been developed under the 1972 order under Section 14A, and we're making arrangements with the board to deliver that service and arrangement. Basically how it will work is very similar to how the cross-border healthcare directive worked. The patient themselves must have a diagnostic by a Northern Ireland practitioner. They then decide that they would like to access private treatment in the south. It's up to the patient to source their provider and then apply to the board for authorisation. One of the things that we have introduced in this scheme to ensure that patients are accessing healthcare which is a similar basis to that which will be provided in Northern Ireland, and that that we are aware of how many applications and treatments are being put through for budgeting purposes, is that all treatments need to be prior authorised before a patient can go into the Republic to have their treatment carried out. This is actually how the scheme is run in the south. But in the UK, it had been under the directive that emergency and some other treatments would have been available without prior authorisation. The patient then would arrange treatment and pay for treatment and then seek reimbursement from the board. There are eligibility criteria to ensure that people that are accessing this are, first of all, ordinarily resident in Northern Ireland, that they have been diagnosed with a clinical need for the treatment, and that the treatment is one that is commissioned by the board, that they're not getting access to care that wouldn't be otherwise provided in Northern Ireland. The treatment will receive a repayment which is up to the value of the treatment in the HSC. This will be discussed with the patient at their application time, and the HRG costs will be available to patients, although they are very complicated, and probably the discussion with the board at this point is very important for the patient themselves. The exemptions to the scheme are that anything which is a long-term care, so any social care elements, will not be paid for out of the scheme, which is similar to the Cross-Border Healthcare Directive. Organs and organ transplants also will not be available, nor public vaccination programmes, and this is exactly the same as the Cross-Border Healthcare Directive. For this scheme, as the prior scheme as well, no costs will be reimbursed for travel or accommodation, and it is the responsibility of the patient themselves that they're stepping outside the HSC in Northern Ireland, and that they should be as assured as they can that the treatment and the practitioners that they're seeing in the Republic are of quality treatment. Now, to help with this, we have been in touch with our counterparts in the Republic, and we're working together to allow patients to continue to access the national contact point, which would have been available under the Cross-Border Healthcare Directive, which gives a bit more assurance for the treatments in the south. One thing that we would recommend is that any patients using this do have a valid global health insurance card or European health insurance card, so that they do not have any difficulties accessing potentially emergency treatment in the public sector, and also that they have comprehensive medical insurance. This is really because if they're in a private healthcare setting and they need further additional treatments which are not part of the authorised treatment, they may have to pay additional costs which might not be recoupable from the board, and the medical insurance really should cover that element, and it's more a safety net, because the EHIC and GHIC will only be able to be used in a public setting. During this period also, the Minister has requested that we do a full policy review and consultation on the scheme and how we would look at this scheme in the future, as the scheme has been capped at 12 months to start with. The next sort of urgent time that we're in at the moment is around the EU settlement scheme. Obviously, the settlement scheme has closed as of yesterday, and to ratify their rights under the EU withdrawal agreement, EEA and Swiss citizens should have applied to the scheme by yesterday. The UK has not extended, as far as I'm aware, to date, the scheme to allow late applications or an extension to application times. Rights under the EU withdrawal agreement include rights to access healthcare, and the settled status is an immigration status to continue to live and work in the UK. Those applying for the scheme will either receive settled status or pre-settled status, and anyone applying will get a certificate of application once their application starts through the process of being considered. The Home Office has made it clear that they will accept late applications, because we're aware that there will be some people who haven't applied, and the Home Office has made it clear that late applications will be accepted under a range of conditions, which, to be honest, I think it's going to be taken on each case, because it's not very clear on what those conditions will be. It's usually, they've said exceptional circumstances, but what those exceptional circumstances, we don't actually know what they are. The Home Office, however, has made it clear that there should be no discrimination on those that have a settled status, or as it's up to the individual to apply. They've advised also that there should be no retrospective checking of settlement status by employers, but however, right to work checks for new employees will include slightly more evidence for EU citizens, and a settled status would be looked for at that point for working purposes. We have shared the sort of, in the run up to the closure in the final weeks of the applications, advice out to our stakeholders to share with their employees and to try and get the final sets of people who haven't applied just yet to get their applications in by yesterday. We've also shared the employer duties with stakeholders across the HSE as well. Now, in terms of access to healthcare, obviously healthcare is a residency-based system in Northern Ireland, and the test to determine eligibility is known as ordinary residence. And for those that have been in Northern Ireland, those EU citizens, before the 31st of December, this would be an EU settlement status. We understand, obviously, that some people may not have applied, and that the applications will be considered, but those that have already registered with a GP currently have been considered to be ordinary resident. They have had an ordinary residence check made, and there will be no retrospective checks on GP registrations. However, if a person was to move to a new GP or to apply initially to a GP that they haven't before, they would go through an ordinary residence check. If at that point a person is discovered not to be registered, we would encourage them to get EU settlement status and to apply to the settlement scheme, and would give them direction as how they can get help to do that. However, all emergency treatment is free at the point of delivery in an emergency department, and any necessary healthcare will not be denied to anyone. However, some people may be eligible for a charge unless an exemption applies under the provision of health services to persons not ordinary resident regulations. However, once a person has applied to the EU settlement scheme and has an application accepted and has a certificate of application, as far as the Home Office is concerned, that person's rights are maintained until the completion of their application, however long that may take, including whether it's reviews of what their status has come out as. I've been told that this could take up to a year. So long as a person has a certificate of application, they still will be able to access healthcare on the grounds that they have currently. In terms of other areas, MRPQ and the the registration of professionals. The registration and dual registration of professionals is ongoing between the north and the south to ensure that services and professionals can still continue to provide the north-south services adequately. We are working with the Department of Health and Social Care in London and Bays on continuing arrangements post the standstill point, which is 2 years, where the UK is still offering automatic recognition for the automatically recognised professions. So work is probably going to get underway in that in the autumn and into 2022. We are working very closely with Bays on updates around the common travel area, and we have regular meetings with them around the regulation compatibility and the regulators working together as the MOU, overarching MOU on the CTA has directed. There's been very little movement to date on that. There have been lots of discussions, lots of sort of research and inquiries, and I suspect that we will have more to tell the committee come the autumn around the regulators working together within the CTA and on the direction of travel for professional qualifications. In terms of the frameworks, for the healthcare, we have 3 frameworks: blood, tissue and organs, and the health protection. There has been very little movement on those to date in terms of getting any scrutiny. There are negotiations underway to try and include more in the frameworks around the Northern Ireland Protocol and the internal market within the UK. And because of that, there hasn't been any further scrutiny taken forward. We would hope that over the summer that the frameworks do get further updated to include those elements, because obviously they're very important to Northern Ireland that those are there and that the frameworks have those agreements. That we will be able to go to scrutiny in the autumn. Obviously, the 4 jurisdictions will have separate scrutiny, and that we would want, obviously, our scrutiny to be able to include details of all the things that will impact on Northern Ireland, as we will be complying with EU regulations where the rest of the UK won't. In terms of the reciprocal healthcare framework, I know that the committee has asked for feedback on that and for that to be taken forward. I have taken that back to the Department for Health and Social Care, but currently there has been no further movement on that or a review of that, and there has been minor movement on the agreement of the MOU under the Healthcare EEA and Switzerland's Arrangements Act, which really is the underpinning piece of agreement that would stay in place of a reciprocal healthcare framework. We've had very little movement on that to date, but we do have regular updates within the UK, and the 4 jurisdictions, and both Scotland, Wales and ourselves are pushing to have some amendments made to that MOU, which would basically be in place of the reciprocal healthcare framework. But we have said that we would like a review of that as well. But the Cabinet Office, again, hasn't asked for an update on that. So just to advise the committee that there's been very little movement on that since our last update. That really is all of the updates that I have on people and services. There's been some movement on some things and not an awful lot of movement on other things, but we sort of expect the second half of the year to sort of start apace with other areas, and we'll keep the committee up to date on those. Thank you, Chair.
Thank you, Patricia. A lot in that now, a lot in both those presentations. So listen, I'm going to be as brief as possible because we are very conscious of time today, but thank you for both the presentations. I'll go back to you first of all, Kathy. My first point is arising out of the what you flagged up in terms of the the 6 month notice and the end of the discontinuations. Can you give us an outline of what the impact of the discontinuations are and whether or not those are being mitigated, or you're confident that those can be mitigated? Can you give us some idea of the scale, the type of areas we're talking about, and the significance of that medication, please?
Okay, so there's a small number of lines at the moment, Chair. It is commercial and sensitive, so I can't provide any details on that, but I can advise that there will be a process taken forward where each one of those medicines will be considered, and the implications of their withdrawal from the market in Northern Ireland considered. So, for example, and I don't know, because this work is to be undertaken in the coming weeks. But so, for example, we could have a situation where it's a particular drug, and there could be a range of other alternatives already on the market. So no further action may be needed. Or we really need to go through it on a case-by-case basis. Chair, we've not been in this position before, specifically for Northern Ireland. Some drugs are discontinued in the UK, and there would be a risk assessment done in terms of the whole population, but we've not been in this position before, so we'll be going through it on a case-by-case basis in the coming weeks.
Yeah, and I'm actually very conscious you and I have discussed these issues at length way before Brexit even came around, and looking forward. But this is where the actual rubber meets the road in that sense. And I suppose I want to ask a more general question around. The Brexit has led to a lot of these things having to be rearranged. New distribution lines, new channels, all of that. The labelling, the licensing, so many issues with medicines. I am conscious, and I kind of tentatively welcome some of the very recent kind of indications that there are some areas of movement that could be quite significant, I think, and I welcome the fact that you have flagged some of those today. But in general, in terms of the negotiations that are ongoing and the arrangements that are being made, it has always been my case that we need to address whatever issues there are. We need to address them positively, but that requires goodwill and good faith in negotiations. Would you be of the view that those negotiations are taking place in a climate of goodwill and good faith, and that would you be confident that will be maintained in order to ensure that we here, and we have a particular vulnerability here in the north, that the negotiations being carried out by London are cognizant of the fact that we have a very specific set of requirements here, and that we need to ensure medicines and medications. I'm struck by the fact that I've heard from some English politicians in recent days that the EU take a legally purist approach to this. That sounds to me that the EU insists that laws and agreements are upheld. So I'm concerned that there would be any sort of poisoning of that negotiation. At this point in time, is there a positive framework, and are issues being worked through effectively in your view?
I believe there are, Chair, and certainly the seriousness of the matter, of the issues relating to medicines, I think is now well understood by all parties, and there's been a huge effort made, I think, from both sides to really understand the issues, and I have no reason to believe there's anything other than a positive tone to those discussions, Chair.
Okay, thank you. A couple then for yourself, Patricia. First of all, on the 26 county, the cross-border reciprocation, I note that you said there that you have to have a diagnosis here to access that scheme. I also note that there are currently 137,235 people waiting for a diagnosis, and that's a 4.7% increase on the same case last year. So that's a significant part of the population who are precluded and excluded from this scheme as a result of not having the diagnosis. So is that not a concern in itself? But also, should you not have been looking at actually accessing the potential for access to diagnosis in the south as part of how we address the waiting list here? Is that not a fundamental first building block of the health treatment?
The scheme, if you have something from your GP that says that you need to see to get a diagnosis, Sorry, probably diagnosis wasn't probably the right word to use there.
Diagnostics. It was diagnostics.
Yeah,
but we do have a particular problem with diagnostics.
Yeah.
These are the people who, So we do have a particular problem with diagnostics.
So if a person does have a letter from their GP to say that they consider they need a diagnostic, they can seek treatment, seek that diagnostic under the Cross-Border Healthcare Directive. The original way the Cross-Border Healthcare Directive worked was that would have been wouldn't have needed authorisation from the board. So the person needs to have a letter from their GP to go to the board to get authorisation to seek a diagnostic. So they can apply for that.
Okay.
Sorry, Chair, if I misled the committee.
Okay, no, that's important clarification, and I do welcome that because it's key that we maximise every avenue we have to try to deal with the waiting list.
Yeah.
In that regard, moving on, what progress is there? So I'm very conscious that that's only one small element of the wider cross-border directive. So, and I have personal experience here as an MLA of sending people or assisting and supporting people to be able to travel across Europe. Often for hips and some of the things that are causing so much pain and distress. None of that is currently available. We're outside of that system. Is there any progress to report in terms of anything further to access that wider European healthcare?
That will be taken forward in the review of the scheme within the 12 months of this scheme. The difficulties around the Cross-Border Healthcare Directive and accessing it is that we do not have the reciprocity with the other nations. So the national contact points in the other nations don't have to provide patients with any information or background on the clinicians that they would be attending. So there's potentially more risk in travelling further afield. Because we do have some arrangements with the South to be able to access the national contact point and to be able, it's kind of, we're working together on this. So that will be considered because, yes, you're very right that there are very different cost elements around Europe. Lithuania and Latvia and Hungary are very much places where people went to get osteo treatments, whether it be hips, knees, shoulders, and they aren't sometimes more cost effective than going to the Republic. But we have to balance at the moment around patient safety and travelling within the current conditions, and all of that will be taken forward in the review that is taking place this year as to whether or not we can extend it wider afield to the rest of Europe. Having said that, most patients that use the cross-border directive originally would have gone to the south.
Okay, thank you, and we'll keep an eye on that one. My question is aimed from the point of view of availability. As well as more so actually than cost. It's about eating into those waiting lists and not allowing the waiting list to grow. So there is cost element very important, but also accessibility and availability are issues there. So we'll keep an eye on that. The final one for me then before I go to members is around the EU settlement scheme. I actually raised this in Chairperson Business. I did an engagement in my constituency this week with a group from East Timor, a group of young children actually who had put together a container of aid for their compatriots back at home. But I picked up significant concern and anxiety among that section of people in my community, my constituency in Dungannon, around their status and around their situation generally. My concern in relation to this, and I understand that people can access medical emergency care, and I think that does and will happen because people need that. My concern is, in terms of the booster vaccine, that people will be afraid to come forward for a vaccine. So that's not something they absolutely have to get, but they're being encouraged. And I think given that we're dealing with a pandemic, I think it will be important that we extend that EU settlement scheme to reassure those people. And the other thing to consider here, and I know this from personal experience of working for many years running a business in this area and for further years working within the health system, that we're totally reliant on these people in terms of both frontline key businesses such as food production and engineering, but also in terms of healthcare and domiciliary care and all of that. So they're particularly vulnerable within those settings, and they're particularly important to us as a community in relation to it. So I think there's really a huge need to address the fact that this could add to any hesitancy to come forward to seek a vaccine, that they may be afraid this triggers a look into their status. And I think that's a significant issue. What's your thoughts on that, please?
We have been in contact with the Executive Office around the communications of the settlement scheme. And I just want to clarify, East Timor are generally Portuguese citizens.
Some are, some aren't.
Yeah.
Some are, some aren't. But also, I'm just using that as one example. You've all the other communities as well.
Yeah. In terms of the settlement status, it would be anyone who is a European. That won't apply to anyone that would have another immigration status. So there is an issue around access to vaccines. And I do know that there has been some discussions, and we have been participating in those discussions around no recourse to public funds. And people that may, some people that may end up not being able to access or feeling vulnerable not to access treatments. And yes, you're quite correct around the vaccines. I do think it's something that we probably should take away, Chair, and look at whether we need communications. And I can also speak to the COVID teams around the vaccine as to whether or not they have had any difficulties to date with the acceptance of and getting vulnerable and marginalised groups in the uptake of that, and to address the settlement status within that mix.
Yeah, okay, thank you, Patricia. I think it is an important issue, so appreciate your commitment to take that and have a look. Thank you. I'm going to go to members now, and so I'll go first of all to Alan Chambers, then I have Jerry Carroll, Carol Nichillen and Paula Bradshaw. So go ahead, please, Alan, and I could ask members to be as brief as possible and panel with questions and answers, please, in light of time pressure.
Thank you, Mr. Chairman. Certainly, I welcome any movement that guarantees the unfettered supply of medicines and medical devices into Northern Ireland after the 1st of January 2022. And I note that Cathy did say that the negotiations at the moment, there was, I think she said, a good tone. But I want to refer back to a presentation that the European Commission Vice President, Mr. Sefcovic, made to a Stormont committee earlier this week. When he was asked about the supply of medicines in Northern Ireland, he's reported as saying, "We are willing to consider taking bold steps if the UK government demonstrate a clear and concrete commitment to implementing the protocol in full." Now, that comes across to me as sounding like some sort of blackmail, and I think it's quite disgraceful that an EU negotiator would try to use the health and welfare of the citizens of Northern Ireland as some sort of a political football. So I just ask Cathy, does she feel that a statement of this kind coming from a senior EU figure, does it compromise or undermine your negotiating position around new arrangements?
I suppose what I would say is that on the positive side is that we have now got and received in a proposal, a written proposal has been received from EU which outlines the details in relation to medicines. Now they are, that's being given consideration and I can't provide any detail on it, but I think that potentially is the more important focus at the moment for me, is I really need to understand the scope of that and how comprehensive the proposals are and the solutions are that are being put forward. Certainly the statement yesterday would suggest, their words are that it's a creative solution, and also that the solution involves the EU changing its own rules. So, we do need to just see a little bit more detail on that. And, I will come back to the committee with that information, Mr. Chambers, whenever I have more detail. But from that point of view, that would be my focus at the moment, is let's see what we've got on the table at the moment, how far it goes, and take it from there.
Yeah, well, it certainly seems to be that Mr. Sefcovic was maybe on a solo run on Monday when he spoke to the committee. Thanks, Cathy.
Thank you, Alan. Going to Jerry then. Jerry Carroll, Leonard Jerry, let's get cashed.
Good morning. Thanks. I have a couple of questions, so we'll just run through them quickly together because I know we're tight for time. First one is on the discontinuation of products. I know Kathy says it's commercially sensitive, but to be frank and with respect, I think we need a better answer than that. And I think we need to find out how many products we're talking about. Is it 4? Is it 5? Is it 20? Is it 15? What's the number? I think it's good enough that commercially sensitive is the argument. And you indicated that they may be easily replaceable. And is that the case? Just for clarity on that. In regards to the cross-border, the new cross-border treatment scheme, why is it only 12 months? And is there an appeals process in place to challenge that? And two other questions. Obviously, the healthcare scheme north and south is important in terms of lack of services, and considering the fact that still to this day hundreds of women still travel north and south for terminations. Has there been any discussions about improving access for women on the island? And then finally on the EU settlement scheme, there's obviously, as you've indicated, some flexibility, even though the scheme has ended, but the problem is the flexibility lies with the Home Office, who aren't always great, to put it diplomatically, when it comes to people with precarious immigration status. And what consideration have they or will they give to people's late applications, being down to being unable to get access to documents from their doctors or from whomever because of COVID, and also if there's a period of time where their settlement status is being considered or being appealed, will they still have access to public funds if there's a period of time where they're unsure or their status is uncertain. Sorry about all the questions, but we're short on time, so I thought I'd just throw them all together. Thanks.
Okay, thank you. So, Kathy, do you want to pick up first, or Patricia?
Yes. So on the discontinuations, the numbers are quite low at the moment, and there's a formal notification process. And when companies notify DHSC, it is on the understanding that the information will be handled sensitively. So it isn't something I can provide more information about. In terms of how those are, whether they're easily replaceable, I think what I said was that we need to go through on a case-by-case basis and see exactly what we're dealing with. There'll be a range of issues. I am sure some will be. There will be other products available. Others may not, and we'll have to look at other mitigations. But the 6 month period of notice does give us a bit of time to allow us to work through that. Thank you.
Okay, and were there other questions then for Patricia within that?
Okay, I'll try and take you through these. The 12 months and whether there's an appeals or a challenge to that. The 12 months really is to get a scheme up and running and to allow us to do a full review of the policy and how it would go forward into the future. Because the Cross-Border Healthcare Directive does leave a gap in terms of how we work with other countries on this. And I think it's important that we get the best outcome for the people of Northern Ireland and that the considerations are made appropriately. We would obviously want to have a full public consultation on this as well to seek particularly information from those that have travelled to try and get the best policy and the best scheme if we're going ahead with it for Northern Ireland. In terms of the sort of agreements around terminations, unfortunately, that's not my area. So, I mean, I would advise potentially that question be asked of the department. And the settlement scheme, yes, the Home Office has been very lacking, because kind of giving details as to when or how they will accept late applications. And what they will accept as an exceptional circumstance. We have tried to get clarity on that, and it is still quite vague. And I think because of that, it just means that we can't, we're not in a position to be advising people anyway. We can advise them to go to the support services, particularly Advice NI and STEPS, to get advice on how they can apply. But yes, if someone has applied and has a certificate of application, basically their status remains as it was. So they will be able to get access to healthcare, social services, etc., as if they did have a settled status until the end of the process, whether that be through appeals and reviews. And as I said earlier, it could take up to a year. They're expecting for those that may go through the full length of the process on that application.
Thanks. And Tricia, could you share with committee I know that you said the advice was pretty vague, but the vague advice from the Home Office, and also if you have any clarity around the access to benefits and healthcare, if you have that in writing, that would be useful. Thanks.
Okay, thank you, Jerry. Carol Nicolin, Carol Lannery, request, Chester on.
Gormaga Carly. So Jerry's asked a question around commercial sensitivity. I wanted to ask that as well. So it's really just a criteria for commercial sensitivity. And indeed, you know, like if you did say there were negotiations going on and you hoped that they would be clarified in the future, you know, could we have a bit more detail on that? The other question really is, I suppose it's around it's already been covered as well, the EU settlement status, but also the MOU and the cross-border, you know, so Tricia, what I want clarification on, if you don't mind, is if, for example, the cost of a procedure or a diagnostic is dear in the south, for example, then what it would be from the HSE here, then where's the negotiating there, and are the patients expected to meet that shortfall? Sure, that's my questions.
Yeah. Go ahead, Kathy.
Yes, on the details around that commercial and sensitive, I can provide something in writing after the meeting now. An explanation around that. The negotiations that you refer to have now resulted in the UK government providing a proposal to the EU, and the EU now coming back with a range of formal solutions. That's what we're considering at the moment. So the negotiations have yielded some outputs, which we now need to just go through the detail of in relation to see how far they go.
Yeah, and Kathy and Chair, just very, very briefly, so does commercial sensitivity, if those drugs are going to be sourced within Britain, where's the commercial sensitivity with, you know, which jurisdiction is it with as well?
I suppose the issue here is the release of information, you know, well, who's it held by? Sorry, your question. That information is managed by DHSC. I suppose it's the easiest. That's Department of Health and Social Care. The companies notify DHSC under certain conditions, and they understand how their information will be handled. And that's why the DHSC share certain information with us, so that we are kept aware, and so that I can update you and I can update Minister, but we don't get into a lot of detail. I'm not at liberty to disclose that, because the information is held by DHSC. It's owned by them.
Okay, so you're not going to have to follow European notices around that commercial sensitivity. So listen, if you can get that in writing, we'd all appreciate it. I'll just leave it there, Chair, and we're pressed for time.
Thank you, Carol. Going into Paula. Go ahead, Paula, please.
Thank you, Chair. Thank you, panel, for this morning. My first question is in relation to what is the situation with approval of new drugs after December 2021 in terms of EMA or MHRA? And then the second one is in relation to the cross-border healthcare provision. So the way I read it is that you source the provider, you pay up front, you cover any shortfall. So why is the same process not accessible to independent sector hospitals in Northern Ireland? So that's the first one. And then the second part to that is, can you go privately to an independent hospital and get a diagnosis and then that allows you then to get into to go to the Health and Social Care Board to then go to the south. So it's really just around the logistics. Thank you.
In relation to medicines and approval, what we anticipate doing is continuing to follow our existing arrangements, and there's sort of broadly a two-stage here. First is the marketing authorisation being given to the drug, so that would be the centrally authorised medicines would cover most of our innovative medicines, Paula, like our new cancer medicines and other medicines that we would be waiting for, and those ones that we would then, so the marketing authorisation is stage 1, so those will all go through centrally authorised route for UK and ourselves, and then in terms of GB and ourselves, and then the next stage is once you've got the market authorisation, the process starts in terms of how NICE will consider them for use within the health service, and we follow NICE, so our aim is that we will maintain those arrangements, and there may be some issues that arise that we need to consider that we're going to be working through now in the coming weeks and months in relation to if there are any differences between ourselves and in relation to any divergence.
Thank you.
Okay. In answer to your other questions, the reason why it currently isn't available to the Northern Ireland independent sector is that it is based on the cross-border healthcare directive, which wasn't available to the independent sector in Northern Ireland prior to exit. This is the reason why it is a 12-month scheme as well, as I've explained earlier. It's to look at all of the various different options, and it would be that if it is the independent sector, we would need to consider that. Should we be allowing this to the independent sector in Northern Ireland? Should we be allowing it to the independent sector in GB? So those things need to be considered, which is why the scheme is a 12-month scheme with a review of the full policy. So yes, we're aware that that is an issue, but as I said, it is based on the cross-border healthcare directive, which didn't allow for access within your home territory. In terms of getting an independent sector a diagnosis, yes, that is quite appropriate to then go take that to the board to ask for authorisation to travel. And just then on Carol's question as well, yes, the patient meets the shortfall between what it would cost to the board or to Health and Social Care in Northern Ireland and the private healthcare cost in the south. So there is a patient element and there is a board element of the cost of treatment.
So can I just come back very quickly, Chair?
Yeah.
I'm just conscious that because this is no longer an EU requirement to have this, and this is obviously something that is desirable, so I'm not knocking it down, but is there not the potential that this scheme could be legally challenged by those independent sector providers in Northern Ireland or in GB? Because it does seem like unfair competition.
To be honest, yes, we have considered that is a possibility with this scheme. It is an arrangement under the 1972 order, and we have looked at that and have considered that, which again is why the scheme is a 12-month scheme, to allow us to consider the full application of this policy rather than the cross-border healthcare directive as such. The full policy of allowing people to seek treatment in an independent sector to have part of the funds to the cost to the healthcare paid back, reimbursed to them, and whether or not that should apply to Northern Ireland, UK, the Republic of Ireland, or to Europe and or wider, because we've also had correspondence and considerations from people going to Turkey for treatment, which wouldn't have fallen under the cross-border healthcare directive. So there's a lot of things that we need to consider, and to give a scheme under elements that would apply, this is why it's to the Republic only. It is based mostly on the cross-border healthcare directive, and then this 12 months period we will consider all of those other options and considerations.
Okay, thanks very much.
Yeah, and I've another couple of indications now in from Ciara and Orlia. So we're going to go to Ciara, and I'm going to ask everybody just to be as brief as possible with questions and replies. Thank you. Go ahead, Ciara.
Thank you, Chair, and thank you, panel. I'm very mindful of time, so I just have the one question. When you were before us on December of 2020, I had asked around radioactive isotopes, as we know they're a crucial part of cancer treatment. So I'm just looking now that we're 6 months post-transition period, if you just have an update on that or any concerns. Thank you.
No, not at the moment. Not at the moment. Our arrangements for radioactive isotopes were affected by the protocol's introduction in January, and our supplies that we relied on, which were flown into East Midlands Airport and then on to Belfast Airport, were actually diverted via Dublin. So that did cause some issues for our trusts. That we've sort of worked through. And my team, as you know, deal with a lot of sort of day-to-day issues in relation to working with the trusts and working with the companies involved. I'm pleased to say that those issues now are resolved and we're back into our direct to Belfast deliveries again. But it's an area we keep a very, very close eye on. Because obviously it's time critical nature of the drugs. But at the moment we've reverted back to our Belfast deliveries. Thank you.
Thank you, Catherine.
Thank you. And thank you, Cara, and thank you, Catherine. And then finally, Orlea Flynn. Go ahead, Orlea, please.
Gormailgut, Colin, and good to see you again, Cathy and Patricia. So my first question, Cathy, you had mentioned in your remarks around some of the stakeholders within the supply chain are awaiting confirmation from the Department of Health regarding future arrangements. And apologies if I've missed some of the context of what you were talking about, but if you could just elaborate a wee bit more on what that is that the Department of Health still have to confirm with the stakeholders. And you had also mentioned that obviously, we've spoke about this for the past couple of months, that a lot of companies and suppliers are looking at reconsidering their options, and that some have rerouted to using going through the south as opposed to Britain. And also that issue around looking at some of the joint packaging with the South. And I'm wondering, with that process taking place, do you have any sort of figures on how many companies are starting to go via that route? And if there has been any issues with that, or, hopefully if that process seems to be, it seems to be progressing straightforward enough, because I think that would be a positive, that, it's not all doom and gloom, and that obviously solutions can be worked out. My second point is around, and I'm just conscious that any time that, this is a public meeting and the public will be, watching in on a lot of these committee meetings, and, some of these issues have been discussed and debated in the chamber as well. And I'm always conscious that whenever we're talking about issues around shortages, discontinuations of drugs and medicines, that, people watch in on this and that can worry them. So it's just important that, I think even the fact that, Cathy, you had mentioned that that drug for lung cancer, that there was that lag period. But the important thing for me was that patients had access to that treatment, that they had access to that drug. And that it was managed and it was worked through. So fair play to you for all the work that you've done to oversee that. But the question on the discontinuations, I'm just wondering so it's small numbers that you are dealing with that has went into the portal where medicines have been discontinued. And, I know we've spoke before about that there's the supply disruption alerts that are constantly in the system. And you had said before, Cathy, that they're, quite normal, and it's a normal thing to have, to get those disruption alerts. And
briefly, please, Orlea.
Sorry, I'm just wondering then, is it the levels that you are dealing with, is that the normal levels of disruption and discontinuation that you usually be dealing with? And can it be down to a global supply chain issue, or is it more as a result of the result of Brexit?
Cathy, you're on mute. You're on mute, Cathy.
Sorry, everyone. Okay, so industry are specifically waiting for guidance relating to what is expected of them when the grace period ends. So that will be informed now by this the offer from the EU and its The analysis of that will then inform, right, okay, what advice can be given to industry. That will then allow industry to start to make firm decisions. And the issue around and whether or not they have to reroute, the companies that have been speaking to me have been advising that one of the consequences of the protocol for them is that they would potentially have to reroute. I have no evidence that they're doing that on any kind of large scale. We don't monitor that at the moment. But they are. So I don't think it's active currently, but it is something that's on the cards from January. There's really no need for them to do anything at the moment because we're in the grace period. So there really is still in the planning process. Shortages and discontinuation is a really important point that you make around reassurance to the public. First of all, the global market in medicines there's always issues arising across the world, and we are dealing constantly with issues. There's a high level of surveillance across the UK, and whenever issues arise, we provide advice out in terms of shortage disruptions alert, supply disruptions alert, and other advice. There's no real significant increase at the moment in those. The thing that could start to change in the future is that, depending, of course, on the outcome of these these negotiations and the proposal that's on the table. We may have more specific Northern Ireland issues to deal with that don't affect the rest of the UK. But in all cases, our aim will be that we maintain continuity of treatments. Don't want anyone to be listening to be worried at this moment in time about their treatment or medicines.
Thank you, Kathy.
Thank you. Okay. So listen, I want to thank the panel very much for your detail and for your commitment to forward on some further information in writing to the committee. I want to wish you all the very best of luck as you continue to work through what are extremely difficult issues and issues of concern for the committee, and we appreciate the engagement on that basis. But to just wish you all the very best and take care in the time ahead. Thank you very much. Okay, members, I'm going to take a very short break there now to try to get us back on track time-wise. So I'm going to take a 5-minute break, please, so if we could come back at 11:48 to resume the meeting. Thank you. And Clerk, can you take us out of public session, please?
30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30.
That's us live now, Chair.
Okay, thank you. So we're now resuming our session, members, and thank you. And I'm now going to item 7, which is a departmental briefing on a UK statutory instrument. Which is the Health Security EU Exit Regulations 2021. I refer members to tab 7 of your pack, and in particular to the clerk's memo on this issue at tab 7.1. The Minister has advised the committee that he has agreed a proposal for the British Government to bring forward the Health Security EU Exit Regulations, which contain provisions relating to health security and health protection for which a devolved Minister has powers to legislate. A departmental official is here today to brief members on the provisions of this statutory instrument and to answer any questions that the committee may have. So I'd now like to welcome Mr. Alistair McInes, who is Head of Health Protection, and Dr. Jerry Waldron, who is Assistant Director of Public Health Protection within the Public Health Agency. So I'll just check first of all, Alistair, can you hear me there okay?
Yes, I'm with you, Chair. Good morning.
Okay, we're not seeing you, or I'm certainly not seeing you at present, Alistair, so I'm not sure. I can hear you, but I'm not seeing you, so I'm not sure if there's maybe a camera issue that you can do something on your end there. I'll go then to Jerry, and just to welcome you, Jerry, once again to our Health Committee meeting, and to check if you can hear me okay.
Yes, thank you, Chair. I can hear you very well.
Okay, so if I can advise members of panel and committee that it's usually easier to hear where people are using headphones and or headsets, and also if people can be conscious of remaining on mute when they're not contributing to the session, that also helps with the sound quality. So I'm going to go back to you, Alistair. I'm still not seeing you. If necessary, we can continue with your briefing without seeing, but as long as we can hear is the main thing.
Yes, I'm sorry.
So can you...
I'll poke around in the background while I'm talking here, but as long as you can hear me. So good morning, and thank you for the opportunity to provide a briefing on the health security EU exit regulations. The regulations were laid in Parliament on the 7th of June 2021. The intention is to have them debated by both houses of Parliament before recess on the 22nd of July, and then for them to come into effect on the 1st of September 2021. If I start with some very generic background, and you can move me along if you prefer to jump straight to the regulations themselves. So very broadly, health security covers activities and measures across sovereign boundaries to mitigate public health incidents. So these regulations are being put in place to ensure a coordinated UK response to serious cross-border health threats. While the UK was a member state of the European Union, the 4 UK nations coordinated and shared information on public health protection with Public Health England, who were the UK's national competent authority and focal point for communications with the EU. The coordination function and the EU structures the UK would feed into were governed by EU legislation that currently remains within UK law. Now that the UK has left the EU, the structures established by the EU legislation are no longer open to us as they would be to a member state. So what these regulations do is repeal and modify retained EU law related to health security so that the UK's health security arrangements continue to operate effectively following a departure from the EU. And they also implement the Trade and Cooperation Agreement insofar as it relates to health security. So turning to the regulations themselves, the powers are drawn from Section 8.1 of the European Union Withdrawal Act 2018 and Section 31 of the European Union Future Relationships Act 2020. So Section 8 of the Withdrawal Act gives powers for a Minister of the Crown to make regulations to deal with deficiencies arising from withdrawal, and Section 31 of the Future Relationships Act gives powers to implement the Cooperation and Trade Agreement. So I'm not proposing to go through line by line, but the regulations are divided into 5 parts and 1 schedule. So I'll cover the main provisions of each part, if that's okay. So part 1 primarily deals with the likes of the citation, commencement and extent. One of the key things in part 1, though, is it establishes the UK Health Protection Committee, and that's probably one of the main new things in this set of regulations. And the committee is comprised of 1 official from each UK nation representing a minister, so effectively a civil servant from a department, and 1 official from each public health agency. And I'll touch on the role of the committee a bit later on. And finally, part 1 of the regulations goes into a bit of detail about what exactly is meant by a serious cross-border health threat. Part 2 of the regulations covers epidemiological surveillance in the United Kingdom. So it requires each public health agency to undertake epidemiological surveillance in its own part of the UK, and it requires information to be collected, and then it requires it to be shared with other UK public health agencies. Part 2 also gives the Secretary of State for Health and Social Care to add, amend or remove communicable diseases or special health measures to the schedule to these regulations, and they do that on the advice of the UK Health Protection Committee. This part of the regulations gives a number of duties to the UK Health Protection Committee. So it gives it the duty to establish procedures for the surveillance and to maintain databases, evaluate data, and communicate that analysis to other UK health protection agencies. Part 3 of the regulations covers procedures for addressing serious cross-border health threats. So it requires the UK authorities to consult each other with a view to coordinating their efforts to develop, strengthen, and maintain their capability to monitor, warn, assess, and respond to serious cross-border health threats. It introduces the UK Focal Point Communications Protocol, and this protocol sets out the principles by which the UK nations will communicate to meet the cooperation on health security element of the Trade and Cooperation Agreement. The focal point for the UK is the UK Health Security Agency, which formerly was Public Health England. This part also sets out the information that must be included in any alert given on a serious cross-border health threat, and it requires the UK public health agencies to act in accordance with the communications protocol. It sets out the duties for the UK authorities when coordinating the UK response to a serious cross-border health threat. And the idea is to ensure as much as possible a coordinated UK approach to assessment, communication, and public health response. So it requires authorities to inform each other, but it specifically enables immediate measures to be taken for informing if there's an immediate risk to public health. And finally, this part sets out the arrangements for communications between the UK focal point and the EU under the health security chapter of the Trade and Cooperation Agreement. It details what happens when the UK focal point is alerted to a threat by one of the UK public health agencies, and what happens if the UK focal point alerts the UK to a threat. It also provides the opportunity for the UK to access the EU warning and response system if both sides agree that that's appropriate. Part 4 also provides powers for the Secretary of State to make regulations, which basically he can add or amend the list of communicable diseases and related special health matters. He does this with the consent of ministers from devolved administrations, and if the devolved administrations wish him to add or remove a disease, he must have regard to that request. Part 5 of the regulations then revokes the 3 pieces of retained EU legislation that this act or this regulation effectively replaces. So that's the legislation that establishes the European Centre for Disease Control, legislation that sets out the rules on epidemiological surveillance, monitoring and combating serious cross-border threats to health, and finally the bit that requires the member states and the Commission to alert each other of serious cross-border health threats. The schedule to the regulations then contains the list of communicable diseases which we are required to notify and the related special health measures that we're required to notify. So really in summary, and you can see that when you look at the EU functions that are being repealed, these regulations just replace a coordination function that was led by the EU and replaces it with UK-wide arrangements with a clear link into the EU systems where that's mutually beneficial and mutually agreed. So look, that's really my very quick run through the regulations. So I'll have to take questions.
Okay, thank you, Alistair. First one I have, and I would be concerned around this, and I think peppered throughout your presentation there, there is an area of some concern. And you had said at the early part of your presentation that the structures of the European structures are no longer available to us. Is that a potential threat to public health and to health security, the fact that we are now operating outside of those structures as a result of Brexit?
I suppose in theory, the UK retains a high level of capability, and where there is a serious cross-border health threat, the opportunity still exists for us to feed into those EU systems. So that'll be very much dependent on any individual threat and the incident. I mean, for example, we have access to those systems to deal with the COVID response. I suppose it's a moot point. Are we better off outside those systems than within them? I suppose it's not really for me to answer. The decision has been taken that we have left them.
Yeah, and I understand that, Alistair. I'm trying to sort of, I suppose, drill into the potential health impacts of that, and therefore how our own health minister could or should interact or interrelate, particularly given that we, and I think this has been made abundantly clear over the past in terms of the pandemic, is that we share that border here on the island with the jurisdiction, the 26 counties.
Yeah.
Is there a recognition that we have unique problems and potentially unique opportunities in terms of cooperation? And is there any scope within this for that unique position to be recognised and for public health to be protected? So we are vulnerable clearly to cross-border transmission of COVID-19, but even flu and any other communicable disease, we're particularly vulnerable, as are the 26 counties vulnerable from here. So is there, I don't get any sense of a recognition of the unique situation of the North in relation to sharing a landmass here on a small island. Is there any way that we can impact that?
Well, there's two angles to your question, I suppose. One is these arrangements are very specifically designed for the UK as a whole to coordinate with the European Union. There's nothing in these regulations that prevents us from dealing directly on a bilateral basis with Ireland. Health protection, health security remains a devolved matter, and I suppose it's entirely free for our minister to make whatever arrangements with Ireland that they're mutually beneficial to them. And on top of that, and maybe I could bring Jerry in on this, the public health agencies on both sides of the border have cooperated for years, and there is nothing in this regulation that prevents that from happening on an ongoing basis.
Yeah, Jerry, do you want to come in on that?
Yes, of course. Thank you very much, Chair. And just to kind of amplify from Alistair's point of view, I mean, we're in the Public Health Agency. We're not involved in making regulations, and we're more involved in responding with them and dealing with the situation we're in. But over the past number of years, before we were faced with the current crisis, I was working along with our colleagues in England, Scotland and Wales, if you like, in preparation for this. I wasn't directly involved with the regulations, but we were working on a kind of non-legislative basis to ensure that that we were able to cope with the situation that was there. The regulations that Alistair said are there because we're in a different situation, a political situation, if you like, at the moment. My concern always was in those regulations that that whatever was going to happen, that what was available and what was in place before, at the very worst, would be no different than what would be in place afterwards. And I made that clear. And indeed, as you've mentioned, we are in a unique position in Northern Ireland compared to the other the other constituent parts of the UK because of the border with the Republic of Ireland. So that does need to, it may not necessarily be taken into account, but as Alistair has said, we have had very good connections with our colleagues in the Republic of Ireland in health protection over the years. And if anything, the COVID pandemic has deepened and widened those connections, and we're almost on a daily communication with them basis now, and I expect that to continue. The one line in the documentation that gave me a degree of reassurance was the line that said, there will be no change, and that is the way I want to see it happening. We conduct and we have agreements with our colleagues in health protection in the Republic of Ireland about how we manage, and that's not just in terms of COVID, but the general diseases. We can't foresee a situation where an individual in Dundalk, for example, will get a case of meningococcal disease and be in contact with an individual from Newry, and that we won't be told about that by our colleagues in the Republic of Ireland and vice versa. the reassurance that I have always been seeking in respect of that is that it will continue. We have had, in terms of the European institutions, particularly, we found very useful over the years our contacts with the ECDC, the European Communicable Disease Centre. I'm reasonably reassured that despite EU exit, that those contacts will continue. And indeed, there's working on the newly established Health Protection Committee to ensure that the oversight group, that Alistair mentioned, and indeed I am currently the Public Health Agency's representative on that group, and that's something that I will be bringing to the table in terms of the outworkings of that group as it arises. So in brief, I'm reasonably satisfied that there isn't going to be any change. Obviously, I'll be keeping a watching brief on it and seeing how things pan out over the next period of time. And if there are any concerns, I'll certainly be alerting colleagues to that.
And in practical terms, Jerry, can you outline for me how that will roll out? So around regulation, around number 11, there's coordination of response, and that it appears that response will be coordinated within this statutory instrument and that will be coordinated in Britain. How is that going to be coordinated north-south in a practical sense, considering we have an MOU recognising the island as a single epidemiological unit?
That's right, Chair, and that's very important. I mean, the discussions that we had within the four nations, within Northern Ireland, England, Scotland, and Wales, recognised and was sort of focused on how we would coordinate within those areas. But in addition to that, we do have, as you mentioned, the whole business of the epidemiological unit. We have had a long period and experience over the years of working together between the emergency services on both sides of the border. There's a long, fruitful cooperation there, and I would envisage that there is nothing in these regulations that would prevent that from continuing and from going on. That would certainly be my expectation. So what's happening at the moment in terms of the excellent mutual cooperation that happens on both sides of the border is going to continue, and it must continue, because as you quite rightly said, we are on one landmass, we are one epidemiological unit, and our responses in terms of threats to the health of populations on both sides of that border must take that into account and must recognise it.
Yeah, I think it's vital that it continues, but not only continues, but develops and deepens, actually, because we have identified that there are areas where there's a need for improvement and potential for improvement. So thank you for that. A couple of quick ones from me before I go to members then. You'd mentioned that there will be a membership from each of the four areas, including one from here. At the start of this pandemic, it was very clear that in terms of SAGE, our Chief Medical Officer was not a full member, had only a kind of observer status in a way, and wasn't able to ask questions. Will we be a full member of this body in relation to the proposal that's in front of us today?
Very specifically, we will be. It is designed that way. It's set in legislation that all four administrations in the UK are full members. And in our initial discussions about the workings of the committee, we have decided that, for example, a meeting can go ahead without everyone being present, but no decisions can be made without the explicit agreement of each administration.
Okay, and the final one from me for now for you, Jerry, and I think it's more for you. In general, would you have a concern as a public health professional that the emphasis of this statutory instrument moves away from public health towards health security, which is a slightly different dynamic? Have you any concerns this will undermine the delivery and the focus on public health?
Well, my hope and my expectation, Chair, would be that it wouldn't. But I think we do need to bear that in mind. And I think that's something that needs to be taken into account, that health security and health protection are not quite the same thing. Health protection has a very wide brief and remit, whereas health security focuses on borders and containing and preventing the spread of disease across those borders, ensuring that a jurisdiction is secure in terms of health, which is, if you like, it's a much narrower focus than the wider brief of health protection, and also because it takes that security aspect into account, it goes beyond the roles and responsibilities of an agency like the Public Health Agency. There are other agencies into play in terms of securing borders, but it's another approach. It's a new way of looking at things. My hope and my expectation is that the wide range of health protection continues to be respected and continues to shape itself.
If I can just come in.
And final one for me then. Yeah, go ahead, Alistair. Yeah.
I was just going to say, it's important to remember then that these regulations specifically deal with the health security aspect. Underneath these regulations, then there's a framework document and other work streams going on sort of related to this that deals specifically with the health protection side and improving the health protection response of all of the four UK administrations. So this certainly should not detract from any of that work. It just deals specifically with how we deal with the security angle.
Okay. And does the regulations tie the hands of the department or the PHA with agreeing a common approach to with Dublin, where that may be in our interest, but is different to the approaches across in Britain? Will that tie the hands of our department here?
No, health remains.
Chair,
sorry, go ahead, Alistair.
Oh, sorry.
Health remains a fully devolved matter. There's nothing in this that prevents the health minister taking whatever action he wants to take. What this does is tells him that under certain circumstances there are reporting and coordination requirements with the rest of the UK. He's free to do what he wants on a bilateral basis.
Okay, thank you. Jerry?
Yes, Chair, in terms of PHA, I have no concerns about our hands being tied in terms of our cooperation with our colleagues on the other side of the border. And we will continue to develop those links as time goes on. As I said, they've improved with COVID, and we will continue that improvement. Hopefully, once COVID begins to recede, it won't make a difference in that.
Thank you both. And I'll go then to Jerry Carroll. Jerry, go ahead, please. While I'm just waiting to check back with Jerry, I'll just check with the clerk. Do we have any other indications, clerk, with you from members looking to ask questions on this before I go back to Jerry Carroll?
No other indications, Chair.
Can you hear me, Chair? Okay.
Okay, so yeah, I'm just checking. Have we got you on the line, Jerry? Go ahead, please, with your question.
Thanks, Chair. Sorry, camera's acting up here. Just a question maybe for Jerry, I suppose, in terms of the SI and the rollout of it, because obviously, I mean, we've had the MOU for dealing with COVID, but I think the cooperation, at least between the administrations, has been not really in existence in any real sense. There's been problems with sharing information, passenger locator forms, and in some cases either seemingly no coordination or a complete divergence of decisions being made. So, I mean, how confident is the department with the SSI coming in that there will be the ability to cooperate at a policy level beyond just sort of the day-to-day cooperation with yourself and your counterparts in the south? Because I suppose there would be a concern that when there's a requirement to take action across the island, both administrations acting in unison. It hasn't really happened at all, maybe on a small level with COVID. What's to say that it's going to happen with this ASI and future health risks emerging? So if you answer that would be helpful. Thanks.
Thank you very much. I think I'm not sure what I can say in terms of policies and people at a level beyond PHA cooperating. It is difficult because it requires two governments, jurisdictions, if you like, to act in harmony, and sometimes the wheels can grind exceedingly slow. What I can certainly, hopefully, assure you of is the fact that there are on the ground, on practical terms, on the day-to-day basis, that the connections are there, the connections are made, the connections will continue between the Public Health Agency and the appropriate parts of HSE in the Republic of Ireland.
Okay, thank you. So members, I want to thank the panel for coming and giving your briefing here today, and we'll go ahead now and deal with the rest of the business in relation to this. But thank you for attending. I don't see any other indications there. So thank you, member. Thank you, panel.
Thank you very much,
and all the best for now.
Thank you.
Okay, thank you. Okay, so members, have there any further issues to raise in relation to that statutory instrument? Keith, can the content of those concerns be raised and forwarded to the department or whoever is best placed?
Chair.
Sorry, Carol, just give me a second. I'm just checking, clerk. Can you advise if the discussions there and the issues raised can be forwarded on?
Yep, certainly we can forward on the issues that have been raised by members to the department to reflect the discussions.
Okay, and your sound is fairly poor, Keith. There, just I'm not sure if you can do anything about that. Carol, go ahead.
Chair, I don't know what happened to have that happen from her, but really what I want to know from maybe that's important, right? It seems that we've lost access to the early warning response, the early warning and data response system operated by ECDC, and its place we have to go through almost the Department of Health in Britain. So, I mean, and they have to be satisfied that there's a relevant threat. So I would just like more information on that because I don't believe it was covered properly, Chair, to be honest.
Okay. Again, clerk, can we seek further information on that?
Certainly, Chair.
Yeah. Any other issues members wish to raise? No. Okay. Well then, can I ask if members then therefore are content to note? Yeah. Thank you. Moving on then, members, to item 8, which is the draft SR on food and feed hygiene and safety, miscellaneous amendments, regs. I can advise members that the Examiner of Statutory Rules has identified a drafting issue with the above SR. The Food Standards Agency has agreed to correct the issue and lay a new draft SR. Are members content, therefore, to defer consideration until next week for that new draft? Thank you. Yeah, members content. Item 9 is the Health Protection Coronavirus Restrictions Regulations 2021, Amendment number 7, Regs NI 2021. I refer members to the papers at tab 9 and in particular to the clerk's memo at tab 9.1. I can advise members this SR makes a technical change in relation to the requirement to produce a risk assessment for a gathering. A departmental official is here today to brief the committee and answer any questions members may have on this SR. I can advise members that the SR is subject to the confirmatory procedure and that the Examiner of Statutory Rules has no issues to raise. So we'd now like to welcome Miss Elaine Colgan, Head of Health Protection Branch. Can you hear us, Elaine?
Oops. Yes, Chair. Can you hear me okay?
Okay. I can hear you there fine, Elaine, and you're very welcome. I know you're normally here on travel regulations, but this one is slightly different, so I'll just flag that to members. And we're also joined by Miss Marion McKeever from the Health Protection Branch. Marion, can you hear me okay?
Thank you.
Thank you. So listen, without further ado, welcome to you both to Fáilte Rómh, and I'll go straight back to yourself, Elaine, to brief members on the SR, please. Thank you.
Thank you, Chair, and thank you for the invitation to attend today. As you mentioned, this was a technical amendment as opposed to a policy change, so I will just outline that, but there is no corresponding kind of assessment of the public health situation at the time because it wasn't a policy change as such, it was a correction of an error. So members will be aware from their previous briefing by my colleague Nigel McMahon that the 4th amendment to the restriction regulations provided for relaxations in relation to both indoor and outdoor gatherings from the 24th of May. So those relaxations were indoor gatherings, not at domestic settings, were permitted subject to a risk assessment where numbers were over 15. And outdoor gatherings were then subject to a limit of 500 with a number of exceptions, and a risk assessment was required where numbers exceeded 30. The regulations in Regulation 9 contains a provision that where a risk assessment is required to be completed, that upon request by a relevant officer, which is an enforcement officer, that the organiser of the event must provide a copy of that risk assessment. So at the time of the 24th of May, a drafting error omitted to connect that requirement for enforcement to the production of the risk assessment under those newly drafted provisions. So RSR Amendment number 7 corrected this and ensured that anywhere in the regulations where a risk assessment is required, that there is always a requirement to produce it upon request. I should emphasise that the requirement to produce a risk assessment was always, the requirement to produce the risk assessment in the sense of develop it was always in place, and enforcement officers could always ask to see it. The only difficulty would arise was if a person refused to provide it, and no further action would be able to be taken against them. I have, however, confirmed with PSNI that there was no impact operationally on any cases that they are aware of at this point that were ongoing between the date of the changes to the outdoor gatherings and the making of this amendment on the 21st of June. I hope that's been helpful, and Mary and I are both happy to take any questions members may have.
Okay, thank you. So I'm going to go first of all to Carol McKillen, and then I will go to Jerry Carroll. So go ahead to Carol McKillen and write it up.
Thanks, Elaine. So the questions I have really is in relation to outdoor gatherings. So in the summer in particular, there's always a lot of outdoor activities right across the piece, should it be festivals, parades or whatever it is, even, summer schemes and stuff like that. So in terms of this regulation, is it still should the risk assessment not be carried by the organiser? As part of this, what you're saying is it should be there, they should have it, and if asked, they should be able to produce it, so should they not be able to carry it? And then, okay, for example, you have a festival and you have like gigs playing a concert on, and you have 500 in for one part. Then someone else wants to go and see another act and you've got another 500. Is there a time difference? Because I'm just conscious that, with the good weather, you might have more outdoor activities because people genuinely believe it's safer. So regarding all that, please.
Thanks, Carol. You were breaking up there towards the end, but I think I've picked up the main points of your question. So the first one, if I understood correctly, it's about the risk assessment and whether the organiser actually has to have it with them at any point in time. So they don't whilst they have to complete it and they have to be able to produce it on request, they do have 24 hours to produce it when requested to do so. So they don't actually have to be able to produce it instantly. With regards to the numbers in outdoor gatherings, Marion, would you be happy to take that question?
Yeah, no problem. The likes of the festivals that you referred to there, Carl, the gatherings would be one gathering. If they're gathering for the common purpose of attending a festival, that would be regarded as one gathering. You couldn't have multiple gatherings of 500 at each festival. It would be, for that one event, would be the maximum. Currently it's 500 capacity.
So
we lost your sound there, Carol.
Sorry, Colin, my camera and my sound is going on and off automatically without even me touching it, so apologies. So maybe festivals is a wrong example, but say for example it was a parade, the Fla in West Belfast, and normally you would have thousands, kids and all, floats and all that attending it. So is that considered one event, or do you have one group of 500 with a break and then another group of 500?
I think it would depend on the events. If it's multiple events going on, then each event would be a gathering as opposed to that full thing. I think it depends on how the event's broken down.
Yeah, I think Marian's right there. I think the main point is the common purpose, and then where the place is. So they have to be gathered at the same place as well with a common purpose. So each event, and it will be difficult over the summer. I'm sure we will have to address queries on specific events as they come through, but it will very much depend on the individual circumstances of the event.
Okay, thank you. And Jerry, briefly as you can, please.
Yeah, thanks. Sorry, sure. Again, my camera's acting up as well. Just in regards of the requirement to produce the risk assessment, just to clarity, that is on request from a police officer or an enforcement officer. And did you say there is a punishment in place within this, or or cooperate? Is there a punishment? Is there a fine, or what is the response allowed, if you will? Charlie, thanks.
Yeah, so there is an enforcement provision that is able to be taken on failure to comply with the direction. I don't know offhand the actual fine amount. Marion, are you aware which one of it is? If not, we can go back in writing just to confirm which of the enforcement notices would be applicable to that.
No, I'm not too sure off the top of my head.
Yeah, we'll just confirm that back in writing, Jerry, if that's okay.
Yeah, I appreciate it. And just finally as well, I mean, is there any grounds for a reasonable excuse or a basis for an appeal if a fine is issued and it's not reasonable? Obviously, I mean, do we know where the scope is for challenge on that? Thanks.
We'll need to look at that when we work out which of the enforcement penalties it would be. So it would be, we'll kind of just build that all into the one response, if that's okay, and come back to you.
Okay, thanks.
Okay, thank you, Jerry, and thank you, Elaine and Marion, for your attendance today and for addressing those issues for members and for committing to coming back with further information. Thank you. We'll go ahead with our consideration now, and good luck for the time ahead. Thank you.
Thank you.
Thank you.
So thank you, members. Have members any further issues they wish to raise in relation to that ASR? Jerry, had your hand up again there?
Quickly. I mean, it may not be an issue, but I think we should maybe, with your obviously and committee's agreement, maybe hold off if we can, because the information I think that we require back is quite important and maybe unsubstantial in terms of changing people's opinion on the SR, but it could be. So I don't know what our time frame is on this SR, but I'd be keen on a bit more information on it.
Clerk, can you advise in relation to timing?
Certainly, Chair. We haven't had a confirmation of the department schedule in that for next week. So the end of the statutory period's the 15th of September. So we can have a bit of time on it. And I know the department just hasn't confirmed when the rule will be scheduled for plenary. I see it's not in the order paper for next week. So I presume that means it probably will be September time.
Okay, well, I'm just conscious. So that would give us time to defer it. I think it would be better if we could deal with it next week, just because we don't know. I take it that sitting days, were there a need for additional sitting days over the summer, could very quickly change the situation in relation to this,
yes,
if I'm correct. So It might be better done sooner rather than later if we can push for the response. That be an option?
No problem. We can certainly get that response away straight away.
Okay, so members content to defer till we receive those responses back. Yeah, thank you.
Thanks, Jerry.
Item 10 then, members. Yeah, go. Yeah, is that Jerry or Keith?
Just saying thanks.
Okay, thank you, Jerry. Okay, members, moving on to item 10, SL1, the Establishment and Agencies Fitness of Workers Revocation Regulations. At last week's meeting, members, you'll remember we received correspondence from the department on this issue, and we agreed to write to the department to outline that we would like to see this come through the SL1 process, as would normally be the case. Therefore, at item 10, there is an SL1 from the department now, advising that it intends to make a statutory rule to revoke the Establishment and Agencies Fitness of Workers Regulations NI 2020. Those regulations were made on the 2nd of April 2020 to give effect to a temporary COVID-19 pre-employment vetting policy that permitted employers to recruit staff more quickly to health and social care posts on the basis of more limited pre-employment checks in order to address the urgency of the pandemic. So are members now content that the department makes the statutory rule? Yes, members are content.
Chair?
Yes,
Sorry.
go ahead, Paula. Yeah.
Thank you. I'm just wondering whether they have taken people on through this, these sort of limited pre-employment checks, and they're still in post. Are they now going to go back and do the full range of checks, or are they just assuming that they're now part of the staff and they don't have to do that? I was reading the papers there. I couldn't get clarity on that.
Clerk, can you provide any clarity, or could we seek some clarity?
We can certainly write back to the department to seek that clarity. There's no problem with that, Chair.
Thank you.
Okay, thank you. Okay, thank you, members. So, members, I am conscious of time. We need to conclude the meeting today at 12:40. We may need to deal with some items of correspondence or forward work programme via email. So with members' indulgence, I propose to move to any other business now to ensure that that's completed, and then we can go back to dealing with whatever we can up to 12:40 and come back to that. So I'm going to go to any other business, and I have an indication there from Carol. Go ahead, Carol, please.
Sorry, Chair, my computer's just going nuts today. It's just to get any feedback on that fire station in Newton Ards, even if that can be shared by email. But I think we need to get it today. It's quite a serious situation.
Okay, so I'll just check with the clerk if there's been any progress in relation to that issue that was raised at the start of the meeting. Go ahead, clerk, please.
Yes, Chair. We've just had a response in the last couple of minutes from the Chief Fire and Rescue Officer. Do you want me to read it out? Are you content with that?
Yes, please go ahead, Keith. I think that'll be useful for members.
So it's also been cleared by the Minister. So it states Northern Ireland Fire and Rescue Service has confirmed that plans are in place to ensure emergency cover is maintained within the Newton Ards area and across the service. The Fire and Rescue Service will continue to monitor the situation. However, the management of bonfire sites does not sit with the Fire and Rescue Service. Fire and Rescue Service believes that local agreement between landowners, the local community and those who have built bonfires is always the most effective means to address these issues. And that's the end of the response.
So, Chair, I'm basically taking from that is that facility can't be used because there's a bonfire on it, but they'll get fire cover from elsewhere, and basically that's it.
Yeah, I think that's broadly what I would be taking out of it as well, I have to say.
I think that's our Chair, I really do.
I'd be particularly concerned. I'm concerned particularly going into, this is traditionally a very, very busy time for the fire service. They do be stretched over a very short period of time, and this certainly can't help. So I wonder, I think we should write back, to be quite honest, to impress upon the Minister. I think it's urgent. There's also a workforce issue here where people work in this station, and I think it's a very poor reflection in terms of those people's ability to go to their place of work and carry out what is emergency cover for the whole community. I think we should write back and express our concern to the Minister in relation to this, that this would be a key piece of infrastructure out of commission in a key period of time for the service.
Yeah, I agree.
Members content with that?
Chair?
Yes, go ahead, Paula.
Chair, I would go further than that. I think that this is a TEO issue. The FIC report is not just about flags, but it's also about how we handle bonfires. And I've met with the local fire chiefs in South Belfast regarding Sandy Road, etc. in the past, and it's really not satisfactory that they are having to risk assess whether if they move the wood or whatever, that then that might kick off and have trouble elsewhere that the police have to deal with. This is a societal issue. Obviously it's in Ards at the minute, but it could well be any town or city across the province. So I think we need to write to 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 ask them what they're going to do about a more comprehensive approach to handling bonfires and the antisocial aspect that they can bring.
Yeah. Sure. I've no issue with that. I mean, that's quite legitimate question to ask, but it doesn't deal with the situation that an emergency service is almost closed down and the staff in that building are hemmed in because of a bonfire. And I really do think kicking this down the can to another department isn't good enough. And I just, I mean, like, if it was in my constituency, I'd be doing something about it.
No, Chair, just to clarify, I was meaning this as an additional aspect that the Northern Ireland Fire and Rescue Service are having to deal with perennially. Thank you.
I think that was, I thought that was additional, and I think that's in that sense. The other thing is, I don't think in relation to a key piece of infrastructure like fire service or indeed any other health service estate that we can take the normal approach of just going through the normal negotiations. I think that that clearly needs to be addressed urgently and outside of the normal processes. I don't think we have time, or it's good enough that we just sort of engage on that issue. It's an emergency service for a reason. Are members content then that we write on both Charles and Paula's lines that we write off to TEO and Health asking for urgent consideration of this matter?
Agree.
Yeah, okay. Thank you, members. So members, now it's 11. Any other items of business today? Any other business? No. Okay, well, I will revert then to correspondence and see how we get on. We have a few minutes left. So I'll draw your attention to a couple of items there. Item 11.2 is a response from the department providing further information relating to the independent neurology inquiry teams, terms of reference, the cohort 3 recall and the neurology services review. Members will remember this was in your meeting pack last week and that we agreed to defer consideration until today and to give members a chance to have a look through that. So any additional comments in relation to that, members? Or are members content to note for now? Okay, and we have said that we're seeking an update as well from the department around a number of those inquiries that are ongoing. Item 11.3 is a correspondence from the Minister regarding the cancer recovery plan. I think that's welcome that is to be noted. I had flagged up earlier in the meeting that I think we need to see some further clarity now in relation to the finances underpinning a lot of these announcements, and to explore with the Minister, and I'm conscious he's in with us next week, to explore with the Minister what negotiations he has had with the Executive or what indications are in relation to Treasury or anyone else. Because if we don't resource these plans with finance and with workforce, they won't get off the ground or they won't deliver what we're asking to. Any other comments or issues on that? The other one that I wanted to flag up, I'm just asked. Yeah, go ahead, Paula. Yeah.
I do agree with you about the whole financial aspect of this, because obviously the elected care plan had a certain amount of money beside it, and the mental health strategy had a certain amount. I'm just wondering, is there any way we could have sort of a collation of all these new strategies that are coming forward and these announcements of what the health minister is going to need, to actually have to see them on one piece of paper, because they're fairly rack up very, very quickly. So it's just really to get a sense of what the cumulative impact would be from all these strategies that have been announced recently. Thank you.
Thank you. Members content that we seek that? Thank you. The last one then in terms of the main correspondence is that I want to flag up is 11.5, which is a reply from the Minister on the autism referrals. And I want to welcome the fact that the Minister has indicated that they will look at capturing the numbers of private diagnoses that are being carried out and that are being accepted by each trust. Because I think, as we've said in committee here before, what gets measured gets done. So it's crucial that we get the measurements of what's happening out there in real time. That's obviously a key issue for so many members of our community. So I think that's a welcome step forward, and I look forward to that being delivered and developed. So members, in relation to the main pack, do members have any other items in relation to the main pack? And if not, then in relation to the main pack, are members content that the actions are proposed? Are members otherwise content with the actions proposed on the main correspondence memo?
Sure.
Members are content.
Sorry.
Orlia, yeah. Very briefly, Orlia.
Just quickly, yeah. So 11.16, it's another letter that we've received from Mesh Ireland around their campaign, and there's been some progress over in Scotland around reimbursing the cost of women who need to get full mesh removals. So I'll not take up time today, but it was just like, I know that next week is marking the 1 year anniversary from the Julia Cumberledge report, and hopefully maybe members might be able to spend a wee bit more time and with the Minister and stuff as well. So, but we can come back to it next week. But I just think that we need to, I know we're talking about legislation and how busy our Forward Work programme is, but we also need to schedule in those sessions with some of the campaign groups that we've agreed to meet. And I know that the MESH campaigners are certainly fall within that bracket. So it's an issue that we can't, I just don't think we can afford to drop the ball on it. We need to give people the time and space to speak to the committee.
Okay. Okay, thank you. Members content with that? And are members otherwise content with the correspondence memo? And then can I ask members that the members that we will consider the table papers and the Forward Work programme via email and agree those via email to conclude today's business? Okay, members, a reminder just that the joint committee meeting is commencing at 1 o'clock with Justice in relation to the joint campus. So thank you, members. And our next meeting, just to flag this up, is our next meeting will be Thursday, 8th of July at 9 a.m. It's an earlier start, members, next week. It's starting at 9 a.m. via video link. Thank you, members. Okay.
Thank you. Stay safe.
This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30.